IVM, in vitro maturation, is different to IVF. We take immature eggs outside of the human body and mature them in the lab. There's data of these children compared not just to IVF babies, but also to babies conceived by sex. There's no statistical differences. Last week's patient, she only made the decision quite recently, and within a week we were able to offer her the egg collection. A week down the track, we've frozen 2 top quality embryos with 1 or 2 more ongoing. Chemotherapy attacks fast-growing cancer cells, but also delicate egg cells. And so if we have this small window of opportunity to freeze eggs which could change cancer survivors' fertility future, why not?
Today we're diving into IVM. It's a new frontier in fertility medicine. And I'm here today with a special guest, Dr Violet Kieu, specialist at Melbourne IVF, CREI fertility specialist, and one of the leaders in a new project at Melbourne IVF, the IVM study, CAPA-IVM study. Violet, can you tell us what CAPA-IVM is and a bit about the background of this study?
Thank you so much, Raelia, for having me on the Knocked Up podcast. I'm so delighted to be here. And you're so generous in your introduction, so thank you again. IVM, in vitro maturation, is different to IVF, in vitro fertilization, where we now take immature eggs outside of the human body and mature them in the lab. This is important because in conventional or traditional IVF, we give a woman, and there's lots of different steps, but largely 2 weeks of hormone injections to grow all the eggs inside. And to have a hormone injection, you have effects of egg growth, but side effects up to and including ovarian hyperstimulation syndrome, where people can get quite sick with excess hormone. So the advantage of collecting immature eggs is potentially time. So you can collect without 2 weeks of stimulation, potentially cost, without the cost of medication, as well as ultrasound, blood tests, nurses phoning you and organising your cycle in 2 weeks. And all this is on a solid foundation of having safety data of over 1,000 births of CAPA-IVM worldwide.
So it's very exciting. It's one really new technology for us, as you say. There's been over 1,000 births compared to IVF, where we have, I think, in excess of 13 million births. Is CAPA-IVM for everyone?
I think CAPA-IVM at this stage is better for some individuals, and that's part of the benefit of having different types of assisted reproductive technology. So at Melbourne IVF, we're trying to offer the trial of CAPA-IVM to those who would likely benefit the most, and that's people who we are assessing as under 38 years of age. So we're separating out other factors such as age-related or aneuploidy or age-related egg changes, as well as women with a high number of eggs, and that might be a formal diagnosis of PMOS, the new acronym, polyendocrine metabolic ovarian syndrome, or those who haven't quite reached the criteria for PMOS but have a high antral follicle count or high egg number, so that with one egg collection, we can offer the best chances to that individual.
Yeah, terrific. And so when we do an egg collection for IVM, it's done a little bit differently to an egg collection for IVF. Can you walk us through what is exactly done differently from the patient experience if they have a different post-egg collection physical experience? And also, as a doctor, how you adapted learning the technique to collect eggs through IVM compared to the training that you would have had over many years in more conventional IVF egg collection.
So patient experience is paramount. As part of our trial, we are doing surveys of patients who have consented to have the IVM egg collection a few days after egg collection and a month down the track to see how they have processed that experience. From a patient point of view, what I say and what the literature says is that there's no increased pain or bleeding complications from the immature egg collection versus the mature egg collection, though it does take longer because you have a smaller target, and particularly our patients already have a higher baseline egg count number. We are wanting to do everything safely and calmly. So a usual egg collection is about 20 minutes, and we've allocated 40 to 60 minutes, just so it's not just the patient has time and the clinician, but the whole team, the anaesthetic team, nursing team, science team as well, to get all the processes correct. So from a patient perspective, in a calm manner, there can be a fast turnaround. So for last week's patient that we did the egg collection, I saw her a month ago, but she only made the decision quite recently, and within a week we were able to offer her the egg collection. And now today, a week down the track, I've been able to hear from the lab we've frozen 2 top quality embryos with 1 or 2 more ongoing. So amazing, from someone who had no embryos left in the freezer to someone who within a week, 2+.
With IVM and the timeline to treatment being quite quick, that really opens it to another application of fertility preservation for cancer patients.
Yeah, absolutely. Yeah, that's an amazing point. So there are so many possibilities. So we have to plan in a systematic way before we offer these technologies. But yes, say, as you may have as well, patients say with breast cancer, devastating diagnosis, or any other type of cancer, and their oncologists may recommend life-saving, life-altering chemotherapy soon, in the next week or 2, right? And chemotherapy attacks fast-growing cancer cells, but also delicate egg cells or eggs. And so if we have this small window of opportunity to freeze eggs, which could change cancer survivors' fertility future, why not be able to improve on this technology so that we have that potential to offer it? Absolutely. And taking that even one step further, sort of another way could be, if we could do this, why not freeze eggs or offer the potential for egg freezing even electively in the future without stimulation? We are not there yet, I don't think, but the fact that Melbourne IVF and you as, our medical director are involved and really support this research shows that we are leaders in the field. And I was thinking about this as well. We are not such early adopters that we have disregard for safety. No, we've seen in other units, such as in Vietnam and in Brussels, which myself and other team members in Melbourne IVF have attended as well to learn from international experts. And we're not leaving it so late that we're laggards, sort of behind the curve. We're sort of innovative, just before the middle, and assessing it on its own grounds. Is this IVM applicable, safe, feasible in our population? And that's why it's a trial. So that we can collect data, and again, as scientists or research clinicians, I and you, we're not fixed to the outcome. The outcome is what it is, and we'll present it according to the facts.
Yeah, I think IVM's really an attractive option for, as you say, women with polyendocrine metabolic ovarian syndrome, formerly known as polycystic ovarian syndrome, because patients, and this is really about 12% of Australian women, so it's quite a high number of women with this particular concern, may have ovulatory problems and not release an egg to be able to try with their partner. But the burden of ovulation induction therapy can be quite high in that patients need to take medications and attend monitoring, and if they do release 1 egg, the chance of pregnancy per month is limited. Do you think for some patients that IVM may be a viable alternative to ovulation induction therapy?
I do. I am seeing that in the women and couples who approach with interest the IVM trial. There are some who have had 8 and some even more unsuccessful ovulation induction cycles, but their egg count is so high that they are at risk, as I mentioned, and don't necessarily want to do an IVF cycle, and just ask, what's the next step? So I'm not saying everyone has to do X number of ovulation induction cycles, but that's what I'm seeing, as sort of a loose pattern of people who've done treatment, had burdensome, like they've gone in, done everything right, taken the tablets, done the scans, done the bloods, had sex at the right time, taking medications, progesterone, triggers, and it's still 1-2 years down, potentially down the track. And what's next? So I think it offers in the ladder of ART, assisted reproductive technology, another option for some.
Yeah, it's very exciting. And I think the more options we have, the more weapons we have in our kind of armory or tools in our toolkit to help patients, the better.
Yes.
What are some of the pitfalls for IVM, and what would you want people listening to the podcast to understand about why in their particular circumstances IVM might not be suitable for them?
There are things that are similar to IVF and things that are unique to IVM. So like IVF, we are collecting eggs, and one of the benefits is more than one egg. We can't reverse time. We can't make the eggs younger. So when I tell people at the age of 40, over 50% of the eggs are genetically abnormal just because of age, and we can't change that with IVM. But what IVM does over ovulation induction is take more than one egg. So you have further chances. So it's like compressing all your chances in that one egg collection. Potential challenges. Well, let me tell you a story. How did I get involved in IVM in the first place? So a few years ago, ASPIRE, which is the Asia Pacific Reproductive Endocrinology Association, had their conference in Adelaide, 2023. And the Vietnamese group who are working with the Brussels group came from Vietnam, many of them, to present their amazing findings. So they had a trial of 500 patients, 250 IVF, 250 IVM. And after the first embryo transfer, no difference in pregnancy rates, about 1/3. That's great, albeit less total number of embryos. But for that population, that was a great proof of concept. A shout out to Professor Rob Norman. I spoke to him, and then he introduced me to the speakers, the Vietnamese speakers, and we got talking. And independently, another doctor on the research team, Associate Professor Kate Stern, spoke to one of the other Vietnamese professors. And in a year or so, we ended up traveling to Vietnam with a research scientist and a clinical fellow to observe on a multi-day study tour of the lab. And they were incredibly generous. And then with their time and expertise, and were able to, with consent, train. And then the following year, independently, went to Brussels, at Brussels IVF, and they also have an IVM program, albeit differently, and there's different ways to offer a service, and that's why it's interesting to see how we can offer it in Australia. If this isn't the right path, so be it. But other countries have shown that it can be done. They have live birth outcomes from it that are safe. There's data on genetics. So that's, our genetic components, our genes, our chromosomes, but also epigenetics, the proteins or around the genes, how things are expressed, as well as 2-year-old, pediatric outcomes of these children compared not just to IVF babies, but also to conventionally conceived or, babies conceived by sex. So there's no statistical differences. The challenges are, how do we become a centre of excellence to meet international standards as well, and in a safe, supported manner, like through Melbourne IVF.
With IVM, you must freeze embryos. You can't do a fresh embryo transfer. So unlike conventional IVF, which can use the backbone of the menstrual cycle as its template and follow the same pattern and be able to put an embryo back if it's safe to do so and achieve a pregnancy in the one cycle, IVM is a little bit different.
Yes.
Can you talk us through the dynamic of IVM in that
absolutely.
way?
So the period cycle is roughly 4 weeks. And the first 2 weeks are sort of an egg growth phase or follicular phase, and the second 2 weeks are a lining of the uterus phase, luteal phase. So at the very beginning, day 1 is your first full day of bleeding, and that's early follicular. All the eggs are small. They're all meant to be the same beginning point. There are different ways to run an IVM cycle, but for us in our study, we are giving about 1 week of the pill so that we can time the egg collection around day 1 or day 2. And actually in the last few patients, we've done the egg collections first on the list, Tuesday morning, allocated an hour. But because of the way we've timed the pill, oral contraceptive pill, they've had day 1 on the Monday. So by Wednesday, literally the next day, tomorrow, they can start some medication for their thaw cycle. So yes, it isn't in the exact same period cycle because the eggs do have to be matured in the lab. So they are not exactly the same age if we had a natural period cycle, but you don't lose too much time.
Yeah, so it's a little bit out of sync. So walk me through, from the egg's perspective, what happens from the beginning of an IVM cycle to when an embryo is frozen.
Yeah, absolutely. So I might just go through the pill because it's a bit confusing, I think. I have to get my head around this as well. But some women in PMOS are born with a lot of eggs. And each of these eggs is competitive against their sister eggs and releases this hormone AMH. They all keep each other small. And that's why some women don't have a period every month. It might be 2-3 months. So sometimes in our trial, we just want to get them back to the very beginning of the period cycle. So we collect eggs around day 1 or 2. They are very small. Eggs themselves are part of a community. They're in a system where they have supportive cells called cumulus cells, like a cloud. And those cells, actually, as I've said, these eggs are competitive. They're all kept small. These cumulus cells keep the eggs small. But once we take them out of the body, they just want to mature. But sometimes they can mature unevenly. So if we do the egg collection on a Tuesday, we put them in a special CAPA-IVM solution on the Wednesday, which contains a protein or C-natriuretic peptide, which tells the cumulus cells just to keep the genetic part of the egg stable, so allowing time for the rest of the egg to mature. And so the rest of an egg are its organelles, mitochondria, other components to it. And so then on the Thursday, we take it out of that holding CAPA solution and then actually put it in a solution containing follicle-stimulating hormone, which is exactly the hormone that we inject women to grow eggs. So we're literally giving it to the eggs outside of the body. So Tuesday, egg collection. Wednesday, holding the genetics so the rest of the egg can catch up. Thursday, put in the follicle-stimulating hormone solution and have a look if it's mature, inject it with sperm that Thursday. And so by 5 days later, the next Tuesday, we'll know if we have day 5 embryos, which we have today. And that's why I'm very excited.
I'm Dr Raelia Lew from Melbourne IVF. When you decide to try IVF, choosing a clinic with strong success rates really matters. Ours are consistently higher than the national average, meaning more patients reach pregnancy faster with fewer treatment cycles and less emotional and financial burden. And ultimately, it means more families are hearing this sound. Begin your journey with confidence at Melbourne IVF. Visit mivf.com.au for more details.
In the trial,
Yes.
the way that it's being run at Melbourne IVF, Tuesday is basically the day where you do an egg collection for one patient.
Yes.
And then find out the embryo outcomes for the patient who had their egg collection last Tuesday.
Yes. Yes.
So it's a great day at Melbourne IVF on a Tuesday.
Yes, as it is every day.
True. And how was the science evolved to figure out what to do in IVM?
I will also couch this that Melbourne IVF, I think we are the first team or group in Victoria. This is a Victorian first trial in a systematic way, working directly with Brussels and communicating with Vietnam. But I do have to say there are other groups, and in Australia, the first CAPA-IVM baby was born in New South Wales through the University of New South Wales, and they were also in collaboration with the Brussels group. And listening to the scientists also from that New South Wales group, when one of their senior scientists put up the egg cycle from the egg inside its follicle with all the signaling proteins and pathways, I've named 2, C-natriuretic peptide, follicle-stimulating hormone, but there are definitely many more growth hormones. It is impossibly complex. And when he presented just this one picture of an egg and a follicle, he's like, this is 13 PhDs. It is what it is. It's people working laboriously, meticulously, understanding signaling molecules so that we can advance to create the best that we can now, mimic the microenvironment inside the ovary. So it's more than, one person. It's being open to collaboration, both internationally, nationally, and also within our unit.
Yeah, so it's really years of research in animal models, human models working
Yes.
together to get us to this point, which is very humbling.
Yes, on the shoulder of giants. Yes.
It's very exciting. And so in terms of our study,
Yes.
we're going to have 20 initial patients in our study.
Yes.
What would your hopes be, without predicting the outcome of the
Yes.
study, what would your hopes be for this study?
Yes. So in a leading unit, such as the Vietnam unit, 33%, 35% live birth rate is 1 in 3 of their 250. So a third of 20 is a good number. But honestly, I want the best for the patients. To have 1 live birth would be the ultimate, proof of concept and also life-changing for the family. More is more. And if that is not the case, then we have to reflect on the future. But our lab is brilliant. They update us clinicians with daily photos of the egg development. You can see a bloody aspirated egg on day one because, we take it out of the ovary carefully and safely. They wash it. And then when it's mature, beautiful and round. And then by day 5, 100 cells. It's amazing that we can actually mature eggs outside of the body. And if we and Melbourne IVF can carry that to a live birth, that is my hope and dream for any family.
Terrific. Violet, we spoke a little bit about hyperstimulation syndrome.
Yes.
This is one of the most serious medical complications that can happen in traditional IVF.
Yes.
And it can be almost completely avoided in an IVF clinic by a freeze-all strategy.
Yes.
But there are some patients who are particularly at risk.
Yes.
And I might speak to one of my patients that I've referred to the study.
Yes. Thank you.
Who was particularly at risk of this particular problem. So sometimes you have a perfect storm and a patient can have a combination of a very high egg count, so-called polycystic ovary, but also their hormones from the brain to the ovary might not be working in the normal way, and that's called hypothalamic anovulation or hypogonadotrophic hypogonadism is the medical term. It's one of the words that's too long for Scrabble because there are too many letters. What that means is the signaling pathway from the brain is not reliable to respond to the safest IVF medications that we can usually use to prevent hyperstimulation. So that was a patient that I was particularly worried about taking through a conventional IVF cycle, and she's one of the patients who you've helped with the IVM trial so far. So thank you.
Thank you as well. It's a collaboration. We see the patients that come to see us, but that's not everyone. And if, PMOS is 12%, if other doctors, in terms of education, so I've written clinician paperwork, patient information and communication, like I would come to you for advice about other patients, and the fact that I'm running this, I'm delighted that you are open to recommending or at least notifying your patients that we exist.
Speaking to the wider Knocked Up audience,
Yes.
would you mind explaining the inclusion criteria for the IVM study at Melbourne IVF in case our audience members might be interested in considering volunteering to be part of this study?
So again, it's based on the research of those who are most successful in other trials. So that is women who are 37 years or under, who have a high egg count, either through an ultrasound showing an antral follicle count, so of 24, or an AMH of 30 or above. And I do just want to add in, if I may, about safety. Don't just take my word for it. To have met the Vietnamese group in 2023, go there in 2024, go to Brussels in 2025, and now in 2026. Parallel to all this has been reading the data, doing literature review, submitting to our Human Research Ethics Committee, who oversee what we do, as well as having approval from the Australian Government, Therapeutic Goods Administration, to be an approved provider of CAPA-IVM. So there are many safety checks and balances as well.
That we've been through. It's true. Whenever you do something new in medicine, and particularly in IVF, the bar is set very high because we are very concerned and feel very responsible for the safety of patients, but also of the babies we create.
Yes, absolutely.
So Violet, I'm going to ask you a few questions about yourself personally.
Oh, okay.
When did you decide to become a fertility doctor, and what was your journey to this area of medicine?
I'll tell you when I decided to do obstetrics, and then when I decided to do fertility. I was on nights just in a general surgical role at a outer metropolitan Melbourne hospital, and I was asked to see a woman on birth suite after a Caesar to see if there was any surgical or gut causes or bowel causes of pain. And sometimes there are, sometimes it's not. At any rate, I saw her. Then the midwife, she was so busy, she said, "Hold this baby." And so as a surgical resident, I held this baby an hour, hour and a half. And I'm like, oh, I could see myself on birth suite. So then I pivoted and applied for ONG. I was interested in fertility myself, and I think both personally and professionally, because by then I was late 20s, early 30s, and I was also considering my own fertility. And reading about it, I went and sat some of the multiple choice questions in the ONG. I got one wrong, Raelia, and it really rattled me. And I thought, I have to be better than this. So the question is, at what age does female fertility decline? I'm 35. No, it's 30. I mean, it's more after 35, but I was like, oh no, I'm turning 30. This is news to me. And if it was news to me, having done 6 years med school, how many years intern resident, years that really there was need for people to know a bit more about this.
And what do you think are the biggest lessons you've learned so far as a fertility doctor?
It's humbling. I'm so impressed by people who pick themselves up and keep on going. Yep. Just a testament to the human spirit, because great things happen to some people and sometimes unfortunate things happen to some people as well. And just being there and holding space for them and being able to provide personal care, but also having that professional knowing, we have supportive counselling. There are referral pathways to perinatal psychologists, so to hold for the ups and the lows and the in-betweens.
And what are you most excited about in fertility right now from a science perspective?
Well, I'm going to just stick to the memo, IVM, but potentially to prevent age-related decline. So if a woman on her 30th birthday, actually in France, on the 29th birthday, the government is sending them out information about fertility. If on your 30th birthday, if you wanted to, go to see Raelia, see myself, and say, I just want to freeze my eggs, and it took a day or so, that would just be magic to prevent what we sometimes see, people over 40, older than that, struggling.
It would be amazing. One of the challenges I see for egg freezing in IVM is that one of the strengths of egg freezing is putting young eggs in the freezer, but one of the strategic strengths is freezing a high number of eggs.
Yes.
And unfortunately, not everybody has the same ovary, and some people have the capability to pick up a high number of eggs.
That's true.
And others don't in a single cycle.
Yes.
And one of the things that we can do to help patients is realistically counsel them as to the number of eggs we think that they should freeze at the age that they are. But quite often, I would say that possibly even the majority of women need to undertake serial cycles in order to do that.
Yes.
So with IVM, if you could only pick up a more limited number of eggs per time, one challenge to use that for egg freezing electively for a lot of women would be that they'd have to undergo multiple procedures.
That's right. But innovation things lag, 5 or so years behind. And if we can have different ways to improve the egg number, so be it. And I think one of the other things that excites me is what makes a good egg. And age is one factor, but there's so many other factors in terms of education, in terms of lifestyle. Yeah. So that's what keeps me up, how do we collect the good egg? And then all those other things, eggs, numbers, good chances, follow from that.
One thing that we might do if we were to use a technique like IVM for egg freezing is really reset again when we do an egg collection. Because if someone didn't need to go through as many egg collections because we were collecting at a time where their quality was absolutely peak and they didn't have to go through the medications, the risk, the burden, then perhaps we'd reset when we did egg freezing to maybe even early to mid-20s and that might work well.
Amazing, Raelia. And this is why I love it. It's the bleeding edge, not just, of the future, of fertility future.
Yeah, well, thank you so much, Dr Violet Kieu, for coming on Knocked Up. Is there anything else that you would like to tell our listeners?
If you're interested in the IVM trial, just reach out to Dr Raelia Lew's team at the Knocked Up podcast.
If you're listening today and thinking about your own fertility journey, know that support is available. At Women's Health Melbourne, Dr Raelia and her team provide compassionate, evidence-based care tailored to your needs. Whether you're curious about fertility, egg freezing, or simply want to explore your options, you don't have to navigate this alone. To book an appointment or learn more, visit womenshealthmelbourne.com.au. You'll find resources, guidance, and a team ready to walk beside you every step of the way. And lastly, please be sure to subscribe and leave us a review. It truly helps us grow and continue to deliver the latest developments in women's health.